Good afternoon. I always feel really bad interrupting great conversation, but we're here to learn stuff. So, my name is Michelle Dillon. I am a certified geriatric care manager with Keep Living at Home and your LAPA president. It's great to see all you here. Just a reminder, when Stephanie sends out the email, it's important for you all to RSVP so that if they need to make extra space in here, they can. So just remember to do that. I don't think I have any more announcements. I'm going to let our vice president talk a little bit about, and the secretary maybe talk a little bit about the fair coming up, because I have been lax in helping them transition over. So Lori has done most of that. So we're going to give her the floor and let her announce anything in regards to that. Thanks for coming, guys.
Hello, everybody. So I want to tell you something just a little funny before we start. I thought that LAPA has grown so big, and I know it has, but I thought Bill Self joined us today, our man Tony over there, and he walked in and I about freaked out for a second. Like, wow, he came today. So that was pretty cool.
And by the way, for baseball fans, it is opening day of baseball.
Yes. So anyways, that was exciting. But okay, so the fair, we actually have about 40 vendors, and we can actually have 50 total out at Rock Chalk. They'll allow us to have 50. So if there's any of you who haven't turned in forms yet, please do so. If you don't know if you've turned in a form yet, or if you haven't paid yet, meet up with Stephanie. She is the gal waving her arm right there. So after the meeting, if you want to get with her and find out whether you've paid, just kind of remember there are two forms. So there's the membership form and there's the fair form. So you do have to fill out both, because to be in the fair, you have to be a member. And membership is still free right now, and then the fair is $75. So, and then that, what? $100 for the fair? Okay, as of now, 75, 85, 95, going up. Okay. Okay, so $100 for the fair. I guess the early bird was 75. Okay, all right. And so let's see what else. For those of you wondering, the day of the fair is from 10 to 1. It's at 9. So we suggest everybody kind of get there, get all their booths set up, and get ready. We cannot bring anything homemade today, so if you're planning on getting up and baking cookies in the middle of the night, just leave those at home. Everything wrapped you can bring, and then with the door prize, we did put in there that we will have, you can bring a door prize. You do not have to bring a door prize, but it might be a little fun conversation piece if you guys want to. But each person at their table is responsible for getting the little, tickets from them, and then, choosing that at a later date to arrange to give it to them. So, so we're not going to be doing that, but, and then you'll also have little flyers at your table. I know how we all love those, where the seniors will come around and get all of our signatures or a chance to win a $100 gift card. That day, the map will be completed, and you'll have all of your company names on the tables. So that'll already be set, so you just go find your table, and we'll all help you as well.
Hewitt. I am with the Laura Caring Hospice and also the LAPA secretary that is collecting all the paperwork. And just an announcement, we are adding to our sales team for hospice in the Kansas City area. So if you know anybody, send them our way.
I'm Lisa Gray, I'm a speech therapist. I have a private practice. Kathy Eisman, Pioneer Ridge and Social Services. I'm the director of Pioneer Ridge Assisted Living. Cynthia Eisman, director of partnerships for Mobile Medical. And I'm Pat Christian, I'm a nurse practitioner for Mobile Medical. Bill Pratt, case manager of Putnam Incorporated. Susan Davis, Putnam CDL.
I'm Ed Schulte. I'm a Jayhawk fan and the CEO of Caregivers and co-owner of Caregivers Home Hospice.
John White with Midland Care. Just take a look at a flyer for an event. Come on Saturday in Topeka for advanced care planning. And this is Midland Care.
Ramona Shoemaker, I'm intake coordinator for Midland Care Case. Amy Rodriguez, case intake coordinator and community liaison for Midland Care. And we just planned it, but it's not on the flyer, but we will have the same thing in Kansas City on the 26th from 5:30 to 6:30, so I will email that out. Literally just got planned today, so.
I'm Sarah Gunn.
Morgan Nelson with Keep Living at Home.
Brent Ketter with Interim Healthcare Office.
Tina Downey, interim Ed Scholar, I was gonna give him a hard time. I'm vice president.
Lisa Chamberlain, owner of Keep Living at Home. Vicki Knight, visiting nurses hospice.
Alexis Whipple, visiting nurses hospice.
Claire Gunner, PU student and hospice intern at BNN. Cassie Jones, the senior and disabled services at Lawrence Douglas County Housing Authority. Jill Kraft with Visiting Nurses Home Health and Hospice. Sam Brummel, Home Health, DNA.
Judy First with Project Lively. Oh, sorry.
Travis Dillon, True Blue Total House Care, we specialize in aging in place population.
Pam Wood, Airway Mortgage, special reverse mortgages.
Okay, thank you everybody for being here. I am your business spotlight. I'll keep it short because I know we're all excited to hear from Dr. Herder today. On the business spotlight front, if any of you want to get signed up for that, if you could just give me your card after the meeting and I'll connect up with each of you, separately and get you on the schedule. So my name is Lori Yoakum. For those of you who don't know me, I'm an RN BSN, graduated from Emporia State. Stingers up. Woo! Okay, that was great. Very good. All right. And I have been, my husband and I started a helping hand from the ground up in 2009. So we're 13 years into it. And before I did this, I was a director of nursing for a home health company and worked the med-surg floor at the hospital. And have always just enjoyed helping seniors. So we have an office right here at Bob Billings in Wakarusa. And we've been there for 13 years, and then we have our Topeka office as well at 21st and Westport. I could not do it without Jolene. She is amazing, and she's been with us for several years as our administrator. And basically, we just specialize in one thing, which is private duty. That is what we do, and we just do anything from an hour to 24-hour care. So overnight care, around-the-clock care. And, Jolene and I do a lot of the assessments and different things ourselves, and we have a whole crew of help that can't be with us today because they're running things right now, but we couldn't do it without them either. And we just have a plethora of caregivers and CNAs that go out and help within the community with all those non-medical tasks. So private pay, long-term care insurance type things, mostly like bathing, toileting, med reminders, meal prep, things like that. So if you ever have any questions about what we do, I left kind of some information for you guys, and that is a little bit about us. So I will introduce Dr. Herder if you want to come on up, and we're glad to have you here.
I guess I could have gotten farther away. Take up more time. So, well, thanks for the invitation. And it's like a lot of things, I had no idea this great organization. I guess I've heard of it, but that's what a great opportunity to network and collaborate to offer things for the seniors. So, and I never knew that the Stinger's up, so that's I already learned something very important. So yeah, and Sarah Randolph gave me that reached out about the opportunity, and we agreed. Maybe since I've been doing concierge care since 2015, I'd talk a little bit about that. Certainly, it's in terms of this gathering, it appeals more to people on the senior end of the age spectrum. So, and it's just a few slides, I think, just to create a little framework, with the hope, of course, that there'd be it could stimulate dialogue and questions to kind of expound. So, and I'm happy. I don't know how you guys usually do it, if you want to ask questions as we go or save them till the end. So, and I guess slide master, if you can go to the next slide. So.
Okay.
I've got my opening day socks on. So. I mostly, if anybody thought, God, he's wearing white socks with a suit, I just wanted to. So just a little bit about me. My wife and I moved here in 1999. She got recruited to Rod Barnes and their group as a family practitioner, and I went begging for a job, and Don Hatton was nice enough to take a flyer on me, and I'm glad he did, because it worked well. So I think people can read the slides. So next slide. So just going to talk about the bare bones, a little bit about what is concierge medicine, the history of why it's been expanding over the past couple decades, and some of the different models, and then just sort of the pros and cons. So we can go to the next slide. In very simple terms, whatever form it takes, it's just that born of frustrations with the system, patients and doctors there's been a growing market to do more, to do things differently, and because of the restrictions of having to follow the rules, which are there for good reason, these situations have arose where physicians or healthcare providers make that offering to say, hey, we can, if you want to pay extra, here's some of the extras we can give, and there's a growing interest in that because of the frustrations with the system. So, so what kind of extras? Really, a lot of it centers on time. There are concierge models growing a little bit in specialty care, but it's really, it all exists in primary care. And the typical primary care provider usually has about 3,000 patients, and I mean, I think we're all aware of this, and the growing demands as far as staying compliant with regulatory needs and documentation requirements. There's a decreasing amount of time for patient care, whether it's the face-to-face care or when patients call in, to be able to attend to those needs promptly. And so that's really time is the big frustration. And so to be able to provide more time, people shrink their practices. All concierge practices are much smaller than a traditional practice. And so as part of that, you can offer all those perks that take time. To be able to attend to things more promptly, when you attend to things, to be able to give people more time. And then because primary care is a relationship business, or that's what a lot of patients, not all patients are looking for that, but a lot of people are looking for a relationship where you can develop a rapport and trust with someone. And that way, whether it's your prevention goals, when you have an urgent need, or if you have a serious need, that hopefully somebody that you feel like you've built that relationship with. So that's, I think, the other big part that it offers. When you have more time for a person, in any realm, whether it's personal or professional, you know that relationship can be a lot deeper and more meaningful. Most of the models too, because of that, we know that the current system does not do a good job with preventive care, and so that's another extra. That's another appeal to people, is that you have more time and energy to be able to devote to trying to stay well rather than trying to return to wellness when something takes it away from you. And then the other big thing is just so often, and I'm guilty of this all the time, when patients ask for things, immediately I think, is it covered? You know, can I do this? I'm interested in this, and you almost sometimes say, no, we can't do that because it's not covered. And so the different concierge models better uncouple the relationship from that restriction. Not that you can't do that in the traditional model, but it's just you're much more uncoupled in the concierge model. So there's 3 different models that you can read. They're classic, hybrid, and direct primary care. And you can go to the next slide. So classic, I think there was a show, I can't remember what it was, I forgot the name, like set in the Hamptons or something. You know, the classic primary care was, you know, really for the people with a lot of resources. A doctor may only have 1 or very few patients, and it was very exclusive. You know, they were at the beck and call, and you know, a lot of times it included spa type services, and it would usually the price tag was $20,000 to $30,000 a year because it covered a lot and everything. And so then if we go to the hybrid model, which is what I do, and I'll expand on that a little bit. Over the past couple decades, faced with these frustrations of feeling more rushed and having less time at the bedside with patients, a lot of doctors or corporations started to create this opportunity to answer to those frustrations, where they said, we'll still do your insurance care, but on top of that, we can offer these extras. A lot of them would offer sort of the executive physical that people may go to the Mayo Clinic for. That's kind of what our model's like, where people come in once a year and you do a lot of extra testing to try to help people understand their bodies and their health better. And then ancillary to that, you also can offer that, hey, let's give you more direct ways. You know, you don't have to go through the phone tree and that sort of thing. And so, but then for all your traditional care, that can still be provided through your insurance. If you come in for sickness or hospital, or if you need lab work, etc. And so then that can take because of that blended model, it can be offered at a much more approachable price point for a lot of patients. Certainly not all patients. So, and then direct primary care. So the real difference between direct primary care and hybrid is direct primary care, there's no insurance. Direct primary care providers don't participate with insurance providers at all, which is good because it actually lowers their overhead significantly. And so they can offer the concierge style, smaller practice size and better availability, longer visits at a little bit lower price point. Typically they have an annual fee or a monthly fee, however you want to break it down, like the hybrid model. But then they usually have fees for other things. A lot of times they'll have wholesale medications they can sell to the patient at a good price. They can best shareholder return. But I think it's good to have alternatives that can, so that they don't have leverage over the complete. I think it's good both ways. To always have that disruptive leverage. So the downsides I think are pretty simple but significant. It costs more. I mean, everyone with insurance. I mean, everyone's spending an astronomical amount of health care, and so then to say, oh well, yeah, it can be a little better, but you have to, you're like spend even more. I think it's a value proposition for everyone, and you can argue that it's worth it, but that's a downside. And then definitely, I mean, the inequity in everything is embarrassing in our country, and this is just one more example of it. Does it really contribute to that? I think that's debatable, because I think if a doctor and a patient decide, hey, we want to do it this way, does it really make it more inequitable for others? Not necessarily, but it's just another glaring example of that truth. I think the inequity, it could benefit from more disruption, and my next slide will expound on that a little bit. But then, of course, we, hopefully need better top-down solutions, whether, if you believe in Medicare for all, which I think would be reasonable, or places like Heartland Health, the federally qualified health centers that can provide to help close that gap. So locally, we have 3 practices that would fit under this category. 2 of them are the direct primary care models. New Care, or Ryan Newhofel, he's been here for, gosh, maybe at least a decade now. And then more recently, Jennifer Smith. And then the practice that I'm part of, Reed MDVIP affiliate, which is, like I said, is a hybrid model. And the next slide, I was just going to explain a little bit more about my practice, just because I know about that. This is my newer partner, Dr. Scarborough. He was a hospitalist for many years, and so Dr. Steve Dillon and Dr. Elaine Kennedy were also doing the model I'm doing. They both retired, and Dr. Scarborough came on to provide for their patients. And then Angela Cloud, doctor and nurse practitioner, is also with us, and she's here today. So, and we do very traditional internal medicine. We still do hospital care. We do a lot of nursing home care. And in the hybrid model, like a lot of that is outside. We have our population of concierge patients, but then also take care of a lot of patients outside that model. It's a separate relationship, like in facilities, and a lot of the patients at Good Life Innovations, which used to be Community Living Opportunities, or CLO. So yeah, and as when I went into it, well, anyway, as I've been doing this now since 2015, and 3 things I think I've learned. One, that cognizance enhances wellness. What do I mean by that? Well, when I started the program, I thought I've got to have secret sauce for people. People are coming in, they're like, all right, Eric, I'm in your wellness program. What are you going to do for me? And there are things I think that could satisfy that criteria. But what I've really learned is having more time to help patients understand their labs and their tests and their symptoms and their behaviors. I've seen it over the years. I'm like, why is this working? And you realize it's just, as all of us go through our day-to-day, week-to-week life, the better we understand how those things all connect, it does improve your wellness outcomes. These models have been shown to improve health outcomes, and I think that's probably a big part of it. It's just that you give people more time, it has a positive effect. The PCP is chameleon. I've learned as I have more time to listen and talk with my patients is, in any relationship, sometimes people say, well, you could be paternalistic, they just may want you to listen, they may want you to, and so it's really helped me to take time and learn that, not to be fake, but, that Bob wants, this is what he wants out of a primary care doctor, and Barry wants something different, and if you give the patients, what they're looking for, it's more productive. And then one of the neat things is I had a lot of patients, some of my old patients that stuck with me where I saw this, or new patients that the first time I saw them, and they'd be the first to tell you, they're so-called hypochondriac, they were calling me every 3 days. And I just talked to a lady yesterday that would fit that criteria, and I haven't talked to her for a year. And so just that comfort of knowing my cell phone. She can call and text every time. Just seeing, it's not me, but just the model I think can be very helpful for patients like that, just to know that if they have a crisis, they don't have to go through the phone tree. Before I wrap up, I think, talking about healthcare inequity, I think it always often brings up to me this big question. With health insurance, it's so much, and I think we all know this, it's so much different than other insurance. With our house insurance and our car insurance, for all the nickel and dime stuff, we just pay for it, and it's there more for catastrophic. And so I think that'd be the big question. All of the astronomical healthcare costs, would they be better if, I know my family pays $20-some thousand plus a year for our health insurance, and so, if we paid $4,000 for, or whatever it might be, even if it's $10,000 for catastrophic, and then paid more directly for our health care, so we could, hopefully have more say and be more of a consumer, whether that'd be better. Of course, with the healthcare inequity, that can't be the option for all. But I think that's just an overarching, question I would pose. So, and with that, after I ask my question, I'll shut up and see if anybody has any other ones.
So, what are some of the?
Do you guys want me to give her the microphone?
Yeah, go ahead and do that. That would help.
She may not give it back, from what I know.
So what are some of the typical medical things that drive patients to you? What are your patients look like in terms of medical needs?
Yeah, I think, like I said, that PCP is chameleon. I've definitely seen it appeals to a different, people for different reasons. I think more specific to this group, a lot of my older patients, they've either had health crises or they know they're probably coming, and so they want the comfort of knowing there's somebody there that can be there quickly. We make house calls, that can see them, that can come to them, if necessary. I do have some patients, like I said, that I sense that they like it because they're anxious, so they. More of the younger patients, we have, it skews more probably average about 70, but certainly have younger patients all the way down to late teens, and some of them are just that they want to be aggressive with the preventive side. Yeah, so I think that'd be the. Yeah, I mean, I guess in the older population, yeah, I'd say the people that have had health crises or expect them, but yeah, I think you could overlap that with people, even if, people are in their 50s but have chronic conditions. Yeah, I've had some people like with autoimmune disease, where they want a quarterback. That's another common thing I've seen, where they come in and they say, I don't really need anything from you other than I have 10 specialists and I want you to be the central repository to help me understand things, but also to, a lot of times those, as we all know, those things happen there's not a lot of great communication because they're also busy. So, which speaks to kind of what you did too.
I'm gonna ask the question, what's the average cost?
Yeah. For ours, it's currently $1,800 a year. So
Payment plans are all up at once.
So most people do it quarterly. So $450 a quarter. That's quarterly. Yeah, and so for ours, it's maybe I'm getting in the weeds more than people want, but so healthcare is looked at as a commodity, and so to kind of keep it compliant and legal, you want to say, what are you paying for? Especially since we still participate for insurance, what's different? And so that's all focused on the wellness exam. And so the idea is you pay $1,800 a year and you get this executive physical, this mega physical where we do a lot of stuff. And then ancillary to that, you get the availability. So direct primary care, I think, they usually have a sliding scale. Young people, it might be 60, 70, whereas people that it might go up to about 110. So like I said, it's a little cheaper typically, but then you have to pay for extras as you go. So yeah.
How are the individuals assigned to the different doctors?
In our practice,
Yes.
yeah, they enroll.
They enroll?
Yeah, so it's just if they
So
choose
it's
to.
not geographic. It's not geographic. It's simply they enroll and then you assign a doctor.
Right. Oh, well, no, they would either enroll with myself or Dr. Scarborough, my partner. Yeah, so it's just if they choose. Yeah. I was trying to
So,
think,
like-
sometimes insurance companies, like people will sign up for Aetna and they may just assign them a doctor. I think that may happen on occasion, but I think it doesn't. I think because they know of our model, I don't think we usually just get assigned patients. So I don't know if that's.
So how do people find out about you?
Word of mouth, most commonly. I mean, we're affiliated with the corporation MDVIP, so they do a lot of marketing, mostly electronic. You know, so like I bet if you type concierge care on Google, it would link to me pretty quickly. You know, they do stuff like that, so they do some marketing like that.
And so do you have privileges with different hospitals?
No, I'm just privileges at Lawrence Memorial Hospital. You know, speaking of geography, I have a patient who lives in Greece. You know, she's from Lawrence but lives there. And I have a patient that lives in Washington, D.C. Because it's a network, there's, you know, at least unique to my model, we all kind of cover for each other. But the great majority, of course, would be local. You know.
Thank you.
Oh, you bet.
On the tests or the examinations or lab work that goes into that $18 a year?
Yeah, to an extent. We pay for the labs and everything, and so yeah. So one cap would be at a certain point if we decided to do, you know, $2,000 worth of labs. You know, at a certain point, yeah, we kind of say we're going to include these, and then there are certain tests like if somebody needed an MRI, we have to own the equipment, and we can't afford an MRI scanner, and so that, I mean, it's not exactly a cap, but we can only do the extra thing in terms of what we can afford to provide overhead wise. So. Yeah.
So since you do a hybrid model, do you have to be in network with the insurance company? Since it's billed part of it to insurance, part of it.
Yeah, ideally, in network with most, there are a few, and then generally we just, because so much of our focus, you know, as far as the business model is the membership, I just do a small I have a few out-of-network patients, and we just do a little copay. I think it's $25 per encounter outside the wellness program. All the stuff that's related to wellness is part of we don't do any billing, but sometimes you just say well care and sick care. If they come in for an ear infection, if they're out of network, they just get a $25 copay. So.
What time is it? 12:33. We're gonna get on time.
Are you currently accepting new patients?
I'm not. I set my, yeah, so you set a cap because obviously if you get too many, you can't deliver on the, you know, what you commit to. So my cap is 400. So I'm not. My partner, Dr. Scarborough, is currently taking new patients. So yeah. So I have a waiting list. It's not huge, but yeah. But yeah. Yeah, sorry, I meant to take my stethoscope out of it. I just saw it on camera.
I thought you were doing a little, like, you know, health fair at the same time.
Yeah. Does everybody feel okay? So, any other questions? Or I'd tell a joke, but I don't know if I know any claimants.
It's an adult audience, so.
Thank you so much for coming out.
Oh, you bet. Thanks for having me. So.
Thanks, Dr. Herter. And if anybody has any ideas on speakers they would like to have, we've had some really good educational, informative stuff. Email the LAPA and let us know. I also wanted to say that Jason has arrived, so if you want to pay by credit card, he is right over there and he's the man you need to see. Is there any other announcements? Because we have some time for y'all to hang out a bit. Oh, yeah, Laura forgot to do her door prize, so I guess you need to pick a number.
I think it's between like 0 and 41, because I counted.
Okay, so 0 to 41.
I'm gonna go with let's do number 5.
Number 5. Who's got number 5 on their little cards? Oh, right here. All right. Ooh. Anything else? Come on up.
Hi, Sarah Randolph, Bridgehaven. I just wanted to make sure that you saw, if you're interested in seeing our 4th and final memory care home, that you get the open house flyer. I'll also have them at the LAPA fair. We are not close to being done, but we're going ahead with the celebration. It's going to be more of a hard hat tour. The house will be partly done. We first thought it would be done in March. Nope. Then we thought April. Nope. Then we thought May. No. And so probably we're still shooting for end of May. I'm going to say probably June. Room for 12 individuals. I've got 3 of those spots taken, so I have 9 openings. And it follows the same model. We have about 17 to 20 staff that are assigned to each home. Lauren Patterson is the one who has to hire them and orient them and train them. But she was a house manager for us for how many years? 6 years. So she knows what she's doing. And then when she was ready to move into the position that we created for Director of HR, she turned that particular house, our 3rd home, over to her sister. And now that her sister's done it for a couple of years, she's actually going to move and manage the new house, so that we have an experienced person at the helm. So that's pretty much all I know. But please come out. It'll be a nice little gathering. And we're all ready for gatherings again.
I think that's it. Oh.
I think I'm loud enough.
See, this is where you want to be a rock star. Visiting Nurses is going to be hosting a healthcare decision day on Friday the 15th that is open to the public regardless of age. It's going to be at the Senior Resource Center. We're going to have 2 fabulous social workers. Sam and Mickey are going to be presenting that. We're going to have, we'll actually have forms for folks to fill out. The notary at the Senior Resource Center is going to be available, so you can do it one and done and get it all done at the same time. So again, thank you, Midland, for doing it as well, because I feel like this is an opportunity from healthcare providers. Talk to your neighbors, talk to your family, talk to your friends. Everyone needs to get these things in place so that we can make sure we all get to direct our own health. So come participate. It's 11 o'clock on the 15th.
Anyone else? Okay. Thank you.